nose or something, but, and then from the tip of the epiglottis down to the start of the esophagus, that's the laryngeal pharynx. So this is all reviewed to you, so. So I think, in the lab, if you want, these arches look like they're very easy to see, but it's a little bit hard to see in yourself. You might look inside a partner, but this actually is a pretty nice photo. It shows what else is here. I think. Okay, the other thing then that will be used to distinguish the various regions of the oral cavity, it will be divided up into an oral cavity proper, which is the area between the teeth. So if you imagine, here are the teeth. I know we haven't talked about those yet, but I'm sure you know what the teeth are. They make this U in the mandibular alveolar process and the maxillary alveolar process make a U, and that space between the teeth is the oral cavity proper. And then between the teeth and the cheeks or lips here, that is called the oral vestibule. And then, so here's an example now of a person chewing. You can see the green bolus of food there. We chew it up with our teeth, especially the molar teeth. And then the vestibule is kept closed by this buccinator muscle as long as it's working properly. And food then tends to stay out of that vestibule, and you're able to make a bolus out of it and then use the tongue to send it back towards the oral pharynx. Okay, gums. So the way gums are described, they are, of course, it's a mucous membrane. They are keratinized, so it's similar to skin, and they have these two regions. They're called, it's proper gingiva or attached gingiva, which comes up around what's referred to as the neck of a tooth, and then you have this alveolar or unattached gingiva, where obviously the blood vessels are very close to the surface. And then they have these little attachments, superiorly and inferiorly, this little labial frenulum. Okay, so that's, and then the gums are going to be on like both sides of a tooth. So on the side that we're looking at now, between the tooth and the cheeks, it's going to be referred to as the buccal gingiva. And then on the other side, what we're not looking at, between the tooth and the tongue, it's going to be lingual gingiva. So gingivitis, I think there's a term, you hear that often. Gingivitis is just inflammation that builds up in this for somebody that doesn't brush or floss their teeth regularly. That can happen for other reasons too. Then the dental formula, you probably know that. Does that make sense to you, that it refers to the arrangement of the teeth in the 4 different quadrants? So if we take the mandibular alveolar process here, we can divide it into right and left, and we see we have 4 different types of teeth: incisors, cutting teeth, canines, stabbing teeth, and then premolars and molars, which are both grinding teeth. The molars tend to have, like, I think 3 or more grinding surfaces, basically, and the premolars have just 2. So here are the incisors. We have 4 incisors, but 2 on the right and 2 on the left. We have 1 canine on each side, 2 premolars, and 3 molars. So we say the dental formula for an adult is 2, 1, 2, 3. That's all that is. So we have 8 teeth in each quadrant, so 32 teeth total. And then the other thing we can, we also, besides permanent teeth, which we're most familiar with, we also know that children have deciduous teeth or milk teeth. So their dental formula is a little different. That's just, we'll talk about that. I have some pictures in the lab, but you can see this is a dissection of the maxillary and mandibular alveolar processes, where the milk teeth have formed, but they haven't erupted yet. So this happens at very characteristic ages for each of these teeth, but you can see that they're getting ready to burst forth there. So let's look at the structure first of an individual tooth. So that part that we observe when we have a person open their mouth, look inside their mouth, is we're looking at the crown, and it's this will be mostly histology here, but it's made out of enamel, very hard, even a little harder than bone. It's a little different than bone. And then that sits over another hard substance called dentin. That makes the tooth. And what we're looking at inside the mouth is the crown of the tooth. The neck is the region where the gums are coming up around the tooth, and then the part that's down in the socket in the alveolus is the root. So here we see this is just an incisor tooth, and we see that there's this hollow space inside each of these. This is the pulp cavity, and you can exit that pulp cavity by following a root canal to the base of the tooth, and then there's a foramen there, an opening that just allows the tooth to connect with the surrounding connective tissue, and this foramen allows, or it's a passageway for nerves and arteries and veins to get into this pulp cavity. So this is, and of course when they do that procedure called a root canal, it's just grinding through the enamel and then dentin into the pulp cavity and then destroying the nerve and vessels. They're basically killing the inside of the tooth. So, and this is an X-ray which just shows pulp cavity, the root canal, the papilla, or the foramen would be down here at the base. So this is where the nerves, and we'll talk about the nerve supply to teeth in a little bit. The nerves would be running through here, but individual branches then would go up through that foramen into the root canal and then to the pulp cavity. And this is just the one of the blue boxes from your textbook where you have bacteria that have eroded away the enamel, worked their way into the dentin, and then here's an abscess where that infection has just gotten down to the bone. Okay, and this is a patient that's had a lot of those dental caries, and they've been repaired with metallic fillings. Good. So the floor of the oral cavity, I mentioned the mylohyoid. I don't have a picture of that muscle in here, but you've already studied that. But when we look at the floor of the oral cavity from the inside, mostly, of course, what we see is the tongue. If we elevate the tongue, we just grab onto the tip of the tongue and elevate it, as in this image right here, we see some characteristic structures down there. First of all, the inferior surface of the tongue is characterized by pretty prominent veins, very close to the surface. And I think somewhere in here, like people will sometimes, that if they have a heart condition and they want to quickly dilate arteries, they'll put nitroglycerin under their tongue, and it's quickly absorbed by these veins too. So that's not why they're there, but that's what you see there. The other thing that you see is, of course, a mucous membrane, but then it's that membrane is going to form a lingual frenulum, very prominent. This is the lingual frenulum, attaching the base of the tongue to the floor of the mouth. The other thing that is associated with that is this lump. This is not an abnormal structure. That is called the sublingual caruncle. And caruncle is just another, just means mound of tissue. And there are two openings on that caruncle, left and right, and it's the opening for salivary glands called submandibular glands. And we'll talk about those next week when we do the glandular GI. But that's where they open up. They're back here underneath the body of the mandible, but they have a long duct that ends up opening right there on that caruncle. The other thing you see here are these little mounds or plica. They're referred to here, folds of the mucous membrane on the floor. of the mouth. There's also a gland underneath that mucosa membrane there that is forming that mound. These are called the sublingual glands. And they don't open up on this plica, but instead they have multiple little openings that just come right out of the plica, and the saliva goes then directly into the floor of the mouth. Okay, so the tongue. Let's look at the tongue itself. So in this virtual human dissector image, I don't know, that I'm sure is very familiar. We do a dissection like this in the anatomy lab. This is not till later in the winter, but students are often surprised when they cut through the tongue and look at the size of it. It's pretty big. It doesn't look that way when we just look inside the mouth, but it's a pretty big muscle, skeletal muscle structure. So if we can divide it up into the apex, or the tip of the tongue, and then there's a large region called the body, and then the root of the tongue, which is attached here to the posterior surface of the mandible. And that, there's a word for that, genio. There's a geniotubercle in there, and again, that's just a word that refers to that posterior surface of the mandible. And there's a large muscle that's going to come out of there, the genioglossus muscle, and that's basically what we're looking at right here. This is the genioglossus muscle. There's another smaller muscle attached here called the geniohyoid. So this, there's a bony structure right here, the hyoid bone. We made a section through the hyoid bone, and I'm sure you're aware of that from your osteology. But so the geniohyoid actually also forms a part of the floor of the mouth. So the other thing you notice looking at the surface of the tongue is it has an anterior region. The anterior 2/3 has a characteristic form. And then there is a groove, that terminal sulcus, V-shaped terminal sulcus right here. And then a very different looking posterior third of the tongue right here with these big lumps on it. So the tongue, and again, it just mentions here things we already know. It's involved in chewing, swallowing. It has an important role in swallowing and pushing the bolus of food posteriorly. It's involved in speaking and tasting. And there are papilla on the tongue, which I'll show you in this next slide. So we're looking at the same image here. The papilla, many of them are the site where you find taste buds. So we have, if we look closely, this is almost histology here, where we have 4 different types of papilla. The fungiform, the vallate, and the foliate, they just have a slightly different shape and different locations. So these big papilla right here, just anterior to the terminal sulcus, are referred to as the vallate papilla. On the sides of the tongue here, on the lateral surfaces, there are foliate papilla, and then around on the dorsum of the body of the tongue, there are the fungiform papilla, and that's what's shown here in this little expanded diagram or magnified diagram. We can see some of the fungiform papilla. There are also filiform papilla. They're mostly just to give the tongue some texture, to make it like grip onto food and help you form a bolus out of a mass of chewed up food. They are not associated with taste buds. But if we look at one of these fungiform papillae, like over here, we're just taking a little section of the tongue, and here's one of those fungiform papillae that's been sectioned through. It's surrounded by what looks like a moat. It has this moat around it, but then along the sides of that papilla, you see these little blue areas, which one is shown, the histology of it is shown here, and you'll deal with histology, I guess, in the spring. But this is actually a taste bud. So each of the papillae will have numerous taste buds. So some people will get confused and think the papilla themselves are actually the taste buds. That's just the location of the taste buds. Okay, so these lumps on the back, on the posterior third of the tongue, those are not papilla. Those are actually lymphatic tissues, lymphoid tissue, lymphoid nodules. So they're not lymph nodes, they're just, they're not like surrounded and encapsulated lymphoid tissue, they're just nodules, but there are a lot of them. And the other thing, there's so in the space between the oral cavity and the pharynx, there's a whole ring of lymphatic tissue, including these lymphatic nodules on the tongue. But over here, I didn't mention this when we were first talking about the oral cavity, but if we review some of these structures, when you look in the mouth, this is the palatoglossal arch. We mentioned that it's formed by a muscle. That's between the left and right palatoglossal arches, the area referred to as the fauces. Once you go beyond that, you're in the oral pharynx. And then posterior to the palatoglossal arch, there's the palatopharyngeal arch, and that would be right here. And between the two arches, there's this depression or fossa, the tonsillar fossa, and that's where the palatine tonsil is found. So when a kid has his tonsils out, that's usually, like the parents will say that, oh, he had his tonsils out. These are the tonsils they're referring to, the palatine tonsils. So they can get really big, they can interfere with breathing, they can interfere with swallowing, and sometimes it's an operation that's much less common now than it used to be in the past. So then, I guess I have another slide of this where we'll talk about the rest of the ring of lymphatic tissue, but we'll get to that in a minute. So let's look just at the palate, the roof of the oral cavity. So I know you've already mentioned, you know about the hard palate made up of these palatine processes of maxilla and horizontal plates of the palatine bone here. So that makes the hard palate. Then the soft palate is actually attached posteriorly here. And it's mostly muscular, the skeletal muscles, but it is very soft. And then it ends in that structure called the uvula, and people, even comedians on late night TV make fun of this uvula, like punching bag in the back of your throat. It doesn't get enough respect, but of course what happens when we swallow, our tongue pushes a bolus of food towards the oral pharynx, and that also pushes the soft palate and including the uvula up against it forms a blockage of the passageway that leads from the oral pharynx to the nasopharynx. So food is going to go to the oral pharynx and then to the laryngeal pharynx, and not into the nose. So that's what that thing is doing. So the other thing that you see, these transverse folds in the hard palate itself, and again, it's kind of like the filiform papillae on the tongue. It's a rough surface that just helps the tongue to manipulate the chewed up food, and so you can form a bolus out of it that's able to be swallowed. And I think the rest of this stuff is pretty self-evident, or we've already talked about it. So now we're looking in a patient's mouth here. We see the uvula of this, and we can see part of the soft palate, the hard palate. I don't really see those transverse folds. They might be a little bit up here. The other thing we can see here, though, are the palatoglossal arch. I guess that's what's supposed to be in the white circles. You see that right here. And you also see the tonsils. These are the palatine tonsils. You see this one especially. You don't see the one over here on the left very well. So you see the palatoglossal arch, the tonsil, and then right here you see a little bit of the palatopharyngeal arch. And if we went back here, this tissue back here would be the posterior wall of the oral pharynx. If we just went superiorly up into the nasal pharynx, we come to this thing called a pharyngeal tonsil up there. That's sometimes referred to as the adenoids. So they're usually, I don't think they're usually removed. So this is referring to Waldeyer's ring, it's something called the lymphatic tissue. So here are the lingual tonsils represented. That's what we saw on the posterior third of the tongue. Here are the palatine tonsils. This is, again, just some loose aggregations of lymphatic tissue, but then you have the pharyngeal tonsil in the nasal palatine, or in the nasal pharynx. So that's pretty much the oral cavity. Now we'll get into the muscles that move that. I think it sounds like maybe you've already gone over some of this. And we'll also talk about the innervation then of the oral cavity itself. And you probably touched on that, have you? Innervation of the tongue and no? Okay. So here's we talk about the chewing muscles, the muscles of mastication. So this is a pretty complicated dissection in the anatomy lab, but we'll go through it here and try to make sense of it. So it's pretty easy to open the jaw. Actually, gravity can kind of open it, but we have some little muscles down here attached underneath to the chin that allow us to drop our jaw. So even if we're standing on our head, we can still swallow, we can still open and close our mouth, but so it doesn't require just gravity. But we can really, really clamp down when we close our mouth. So if we're chewing on something that's really tough, we could do it hard enough to break teeth, except that we have nerves, sensory nerves, going into those teeth that very quickly, like reflexively, tell our brain that we're putting too much pressure on the teeth. So these are the muscles that close our mouths. Some of them are familiar. You can actually see them at work. So this temporalis muscle, which takes origin superiorly here from the temporal fossa of the cranial cavity, big fan-shaped muscle. Then the muscle fibers converge onto a tendon that is going to attach to the mandible, in fact, to the coronoid process. We don't see that so well here. The other muscle that we see right here now, even more superficial, is the masseter muscle. So that has an inferior attachment to the angle of the mandible, and then it attaches superiorly to the zygomatic arch. This bone that's partly zygomatic bone, partly temporal bone. The zygomatic process of the temporal bone, which you see here. So you can see how these muscles are pretty stout, and I'm sure you've noticed those in people chewing hard. You can just see the masseter and the temporalis muscle working away. There are two other muscles that are involved in this chewing process, though, but we can't really see them in a dissection like this. But we have to go into the space that's medial to the ramus of the mandible. It's called the infratemporal fossa. And to get in there, I have another slide in the lab part that shows this maybe a little bit better. So we've dissected away the masseter muscle. We've just taken that away. That's taken away here. We've taken away the temporalis muscle, and we've cut away most of the ramus of the mandible here to go into that space that's medial. And then we see two muscles, one slightly just lateral to the other one. Here, this is the most lateral one. Just medial to it is this one right here. This more medial one is called the medial pterygoid muscle. And you can see, look at the way these fibers run and compare it to the masseter. They run in almost the same plane, right? So there's the masseter muscle and the medial pterygoid that both attach to the angle of the jaw. They form like a sling. So when they both shorten, they just haul that mandible superiorly, close the mouth very tightly. Of course, the temporalis attached to the coronoid process here is going to do the same thing. But when we talk about chewing muscles, that lateral pterygoid looks a little weird. How's that going to close the jaw? It really doesn't. So as you look at it, you might be getting some ideas about what the role of the lateral pterygoid will be in chewing. So if you open your jaw as wide as you can, you feel the head of the mandible move anteriorly, right? It comes out of the fossa onto the articular eminence. It comes forward. You feel that? What do you think is pulling it forward? That's right. It's the lateral pterygoid. So its job is to allow you to open your jaw maximally. So how do you get the jaw back in? When you close your mouth, how does it go back into the mandibular fossa? So we don't have a specific, separate muscle that does that, but if we look at these inferior fibers of the temporalis muscle right here, attached to the coronoid process, they're the ones that will do that. They'll just retract. So the lateral pterygoid protracts the temporalis muscle. Part of its job is to retract that head of the mandible back into the fossa. Okay. So let's talk about the innervation now. So you know all the nerves, all the players in this, I'm pretty sure. And I don't want to make this too twisted. There's a lot going on here, though. So, and I tried to make this list of what we should be expecting, and then here is the list that tells us what carries out those particular functions. So if we go through this top list here, there's going to be a nerve, a motor nerve, that allows us to open and close our mouth, move our lips around. And you know that's going to be the facial nerve, right? There's also going to be a motor nerve that regulates opening and closing of the mouth. So, but that's what we just talked about. So the trigeminal nerve, you know about that, right? Three parts of the trigeminal nerve, and all three parts have sensory components. One part has a motor component. This is all familiar, right? Mandibular division of three. So if I asked you what closes the mouth, which nerve is innervating the muscles that close the mouth? Say what? Okay. So sometimes I think of 5 as V1, V2, V3, Roman numeral 5. So which one of those would be closing? Which one Yeah, very good. The mandibular division, or V3. Yeah. So it's the only one that has motor. So when we have our mouth open, we want to close it. That's going to be the job of those muscles we just went over, the masseter, the temporalis, the medial pterygoid, but they are innervated by the mandibular division of the trigeminal nerve. So we're also going to expect to innervate the skeletal muscles of the tongue. Any ideas there? I heard a B2. Hypoglossal, I heard. Cranial nerve 12. Yep. That's it. So the tongue, all the muscles of the tongue are innervated by cranial nerve 12. I just remembered I'm supposed to look at the clock. So, do you want to take a break right now, or I just realized we're a minute past. Let's take a little break, and then when we come back, I'll go over. I have a few more slides. We'll take a break before we dive into the rest of this innervation, and then we'll go over. We'll use some of our lab time to finish this, but the lab is pretty. This is going to add to this anyway. So, okay.